esophageal sphincter, the cricopharyngeus, to demonstrate here's an inlet patch or gastric heterotopia here, just actually two of them across from each other. And then right here, the cricopharyngeus muscle, and this is the esophageal side of the septum, and this is the Zenker. So this is a fairly shallow diverticulum. I'm joined here by Dr. Moamen Jabr. We have Deepa. Thank you for getting us to help with this very nice gentleman who has been having some hoarseness of voice, and likely due to retention of fluid and saliva in the Zenker that is overflowing to the vocal cords. So we are going to demonstrate the Z-poem technique, and I like to inject on the septum. This is kind of riding on top of the septum, doing our incision and doing the myotomy subsequently, and then finally we'll close with clips. Okay, needle out. We'll go ahead and start injecting. Needle out. Inject. Stop. Thank you. Go back. Okay, I'll take the hybrid knife. So we use the hybrid T knife from ERBE. Before the case, we were discussing the pros and cons of doing just a freehand septotomy versus doing a Z-poem style. And at this point, for a small diverticulum like this, seems like both techniques would likely be equally effective. I have personally moved on to the Z-poem technique completely a few years ago, based on some concerns about leak, and also to ensure that we have a completely closed field after the myotomy. And usually the post-operative care, I know how you do this at your institution, Moamen, but usually I'm comfortable discharging them the same day if I'm not concerned about any leak. We do give them IV antibiotics, keep them on a clear liquid diet for the first day, and then full liquid diet for 2 more days, and soft diet for 5 days. In many institutions, the gastrographin study is a must after these. Sorry, having a leak. So we're trying to get the patient grounded, and we have the hybrid knife almost ready to go. Any issues with irrigation, Deepa? I usually use these under CO2 insufflation. I have a low flow CO2 regulator that would drop the insufflation rate to a minimum. Usually in third space, this is recommended so you don't end up accumulating gas extraluminally. In this case, for example, crepitus is a common byproduct of these procedures where the neck gets puffy and swollen. Typically more of an inconvenience rather than a true complication. But antibiotics are needed. I do send these patients home with 3 days of antibiotics. I don't know if you do the same. Some people only rely on single dose IV, but I think antibiotic coverage is definitely helpful. What else? There's typically sore throat for a few days. I have not been getting a lot of severe pain. Mostly over-the-counter painkillers are sufficient, and usually that takes care of things. Are we good now, Deepa, on the irrigation? Okay. So see, this is a very boggy septum because now we have good injection underneath of it. The hybrid knife, whenever you are ready, before we lose our injectate. My strategy usually is to make a very small incision, just enough to admit the cap, and then slowly I maneuver my way to both sides of the septum. So I dissect on the esophageal side and then dissect on the diverticular side and isolate the septum in the middle, and then I do the septotomy at the very end, and then we close with typically, in this case you would want, because this is a fairly tight space, the best thing is to use short stem or short-tailed clips. Okay, so just getting the ERBE machine.
So can I clarify? So I think the Z-POM you're gonna demonstrate shortly here. The other septotomy technique is basically using a knife to cut down the septum without making any mucosal incision. We basically cut from top to bottom and stop once the muscle starts to thin out or disappear. And then at the bottom, we close that incision with a couple of clips. There are advantages and disadvantages, of
Need
course, to every
algebra.
technique. With the septotomy, ideally, we won't get a gastrographin swallow next day. So our protocol is that we keep patients NPO and get gastrographin next day. Looks like we're ready to start here.
Yeah, so trying to get a simple cut and trying to align all my petals here. So I try to centralize my incision, so that gives me a little bit of. I'm not getting much of any
It's not
injecting.
no. Has it
Oh, there
been
we
primed?
go. Yeah, now it is.
Yeah.
Okay, so we will now gently make our way through to the septum. I am also increasingly reliant on water pressure to open the field. As you can see, we need a little bit of additional cut here to widen the space. And as I'm injecting and cutting, and then I always trim the residual dead mucosal tissue after the cut, so we are able to keep a clean field as much as possible. As you can see, we still have some arching fibers here, so we're not, and I can demonstrate that we're not yet at the level of the.
Nice.
Yes, so now we are just opening these muscularis mucosal fibers, and then we have all the freedom to inject on both sides of the septum, to the right and to the left, as you can see. Clearly, we're not in the submucosal plane yet, so I am going to gently see if I can get my way in there.
So Mohammed, do you think there is any advantage to using a tapered cap in this situation, like a hood, for
Yes,
example?
I think it definitely would help. Ultimately, if you are aiming to make the mucosal incision as small as possible, that would help. However, at my home institution where I do these, I usually use pretty much the same straight cap and gently inject, and we're getting very close. As you can see, we're already seeing the muscle fibers of the cricopharyngeus ahead of us.
Sorry.
So we just need a little bit of.
Is it injecting? Is the knife injecting?
Yeah, I think there's a little bit of a. I'm trying to see how much, and it's not getting much of any blue.
Yeah, it's not.
See
it's
right
not
there,
injecting.
it's not injecting. Yeah, it's delayed. Why don't you ramp up the pump? So we're getting close. As you can see, we're not. This is not wide enough to get us in yet, but we're not that far. Meanwhile, as we fix problems with that pump, I'm going to go ahead and open that side of the septum to the diverticular side, if I can. Gentle trimming, usually. So isolated that side of the septum, and then gentle trimming on this side too will do the same trick. Yeah, that's better. Thank you. So you can see already we have identified the septum. I think we're almost in. Now we can work on the left side. This is a kind of a nice clear submucosal space on the diverticular side. I'm going to see if I can get myself positioned a little bit more confidently. There we go. Okay, and this is the other side. You can kind of gently dissect the esophageal side. And leave the septum right in the middle of our field.
That looks good. No, keep it this way. You use precise sect, right?
Yeah, I like precise
dissection?
sect for my dissection.
Yeah. It's set to 3.5 here. Is that what you use, or
Yeah,
do you want higher than that a little bit?
I'd probably go to 4.
4,
if I could.
I'm gonna turn it up for 4. Now it's on 4.
Good.
Yeah.
So so we are kind of widening. The key thing is to get to the base of that diverticulum on the esophageal side, because if you leave any muscle fibers here, so this will take us going a little bit deeper than usual, maybe. Although you can argue this is only 1 centimeter in depth, we could use to dissect a little bit more. So we have a good depth on the esophageal side. Here's the septum, which is a cricopharyngeal muscle, and here is the diverticular side. I think I've created a little bit of intramuscular dissection here, inadvertently, not by choice, but we can always come back and trim the rest of these at the end, because to me the goal is to not create any mucosal damage on the septal side, because it will be almost impossible to clip these shut. So I am willing to take a little bit of a muscle injury on this side this early on as a trade-off to avoid any
Which is basically the same principle even in a poem.
Right.
When you get like
Correct.
a tight G junction or submucosal fibrosis,
correct.
you typically lean more towards starting maybe some superficial myotomy to go deeper rather than risking a
correct.
mucosal injury that can be a
Can
serious
be
complication on the procedure.
Correct. So
side.
same thing here, and I think we might be actually in decent shape to start the myotomy now. What do you think?
It looks really
Mohamed?
good to me.
So here's the septum is right there. We have just enough room for the cap
yeah.
to get in. And mind you, if you think you're too superficial, you can always expand the cut as you get through, after you get to the base of the septum. So we'll gently cut through, just making sure we don't cause any mucosal injury on the other side. So we'll kind of stop there and come back.
And I think Dr. Mohammed here is using for this part the hybrid T-knife because he is an expert. But for those who might be worried about mucosal injury, an option is to use like a scissor type knife, like
Correct.
the SB knife or the clutch cutter from Fuji. And those are basically knives that will only cut what's between the blades.
Right.
I personally use it for the septotomy since we don't have the mucosal protection. It's also good to protect the opposite posterior, like esophageal wall, and the opposite diverticular wall.
Yes, so of course, you know, the choice here is yours. I know the scissor knife has been increasingly popular for this indication. I have been using, so here we're making some progress on the myotomy. Still have a lot of muscle to cut on this side. I have to say this is a little bit above average in terms of thickness. So we still have some work to do. But you can see it's thinning down some. The septum is definitely thinning down some. Here's the diverticular side. Always good to build a cushion. We'll put the cushion here too. And here's what's left of that septum in between the two. Obviously, we're not down to the base of the tick yet, so However, I can tell it's thinning out to the point where we probably are at the esophageal.
Yeah.
This kind of blends into the MP of the esophagus, the muscularis propria. So here is the myotomy site, both sides, and here's our mucosal incision. What do you think? Should we go deeper, Moamen, or should we?
Looks pretty deep. Can we maybe check on the diverticular
Side,
lumen
yeah.
itself and compare the depth?
Yes. Getting rid of some of the submucosal fibers.
Yeah.
These can create sometimes a little bit of a thicker residual septum, so I'm trying to gonna go a little bit deeper here.
Yeah.
Okay, so that's probably at least 2 centimeters.
Looks really good, yeah.
So let's see what's happening on the diverticular side. Let's flood it.
I think we're already below it, right?
Yeah, it's pretty superficial.
Yeah.
I like the water jet technique or the flooding technique because A, that shows you if there's any mucosal injury.
Nice.
B, it does sort of open up the space more than CO2, and it's a much more gentler way to test your test the mucosa. On this side, as you can see, that's a common side effect where you see a lot of blue on the esophageal side. Patients have dysphagia on the first day or two until a lot of this goes down. So it's not uncommon that you see some stenosis here. However, all the swelling will go down once the, here's the ectopic mucosa, once all the saline is reabsorbed. I think we're deep enough. I'm happy with the cut. Let's take one final look before we close, just to make sure there's no bleeding. Here is the base. And if you have any doubt that you're deep enough, you can always just halfway out, please. This is what I call the last cut of good measure. So you're okay, let's get some clips ready, if you don't mind. Again, I like the short stemmed clips, 11 or 16. And this patient will be admitted overnight. Thank you so much, Deepa. You can take that. And then we'll get a swallow study tomorrow with gastrographin. One thing I learned the hard way, clipping in a very tight space like that can be challenging. Sometimes the clips might tend to go over to the esophageal side or the diverticular side, and they're not in a straight line. So it's not as easy as clipping a poem incision.
Yeah.
So you always have to stay.
It's a tough location.
Yeah. So I tend to overclip the underclip to avoid any leak inside the site of the myotomy or the pocket. 11 would be good. Yes, please. So these are the Microtech 11 millimeter clips. I think they're perfect for small spaces. I also like them when I'm doing poem in a narrow esophagus, not dilated, because usually the lumen is constricted and you don't have a lot of room to work. And after I apply my clips, I'll show you a technique, also the water, I call the stress test of the incision, which is flooding it with high flow jet of water to see if you have any areas of or any spaces that would allow a leak. Okay. So I'm going to try to start from the top because that will get me a little bit more. Go ahead and open, Deepa. Give me rotate to 12, and actually not bad right there.
Yeah,
Stay where you are, Deepa.
Looks good. Looks very nice now.
Okay. Close. Take that. Okay, let's take another clip. So I'm going to try to keep the lip on the lip of the incision. I do have one lip a little bit overriding, which is a common problem. You have one side sort of arching over the other side. But I'm going to try to keep the site in check. So I am, let's get a few more clips ready. Thank you. Usually we apply anywhere from 4 to 6, sometimes even 7. Again, I tend to overclip than underclip to avoid any leak.
Yeah.
All right, Deepa, go ahead and open for me. Okay, now come over. So now I have some mucosa from the top. I'm trying to exclude that if I can. Again, that's why sometimes it's a little bit.
Nope.
Go ahead and open.
That's nice.
So I'm trying to come back right on where we placed the first one. Close. Deploy. Sometimes you tend to grab mucosa from the top or the bottom, which would narrow the field significantly. At a minimum, we'll need this clip and another one at a minimum. So here's just a minor mucosal injury. This is not, should not be a source of concern. And this is clip number 3 coming across, again perpendicular on the incision. Right, Deepa, go ahead and open. Okay, you're in good location, Deepa. Stay where you are. Okay, before I deploy, I'm gonna just take a good look. Refractory index of water is amazing, so if you have any problem seeing from bubbles or whatever, water is your friend here in these tight locations. Okay, I might move down just a little bit so we don't have a clip-on-clip phenomena. Okay, go ahead and take that. Close. Okay, deploy. Okay. We don't have a whole lot left to clip, but at least one, I would say, which is the top of the incision right here. This is where a small clip makes all the difference. If you have bulky clips, there's no way you can really see what you're.
In this location.
Yeah, it's very hard.
Stem clips,
yeah, those are very hard to work
no
with.
Way.
Okay.
I tend to be less generous with clips, unlike you.
You tend to be less
generous.
okay.
Yeah, I believe that once you approximate mucosa, it just closes. But
close, but don't
with
take.
my trainees,
I
have the saying. I tell them, if this clip is gonna make you sleep better at night,
yes,
let's go for it. Add as many clips as you.
So you're right. So I could probably use, but you're right. This clip is causing a seal that is in that area. I'm flooding it to see how much.
Yeah.
And I'm not seeing any
leak.
Any leak. Yeah. Go ahead and take that, Deepa. Yes, please.
But it's definitely better to overclip than
underclip
and then come back put more clips.
Yes. So let's test the whole incision. Here's the incision. What do you think, Mohamed? Do you see any leak or?
Looks really good.
Yeah. So
very well done.
So I think. Sorry, I'm okay. Do you have any concerns, Deepa, about the left side? Right here? Okay, so I'm going to listen to you and take one last clip of good measure. Right there? Okay, one last clip, please.
So that's the clip to sleep better at
This
night.
is the 2 a.m. clip, I call it. This is the one that you don't want to be called. You don't want to be called at 2 in the morning.
Yeah.
Again. I trust the judgment of my staff and nurses, and they actually correct me quite a few times because it's again, this is a team sport.
100%, yeah.
Deepa has done so many of these. She can tell when an incision is not 100%, and I will listen and deploy one more clip because it's again collective judgment is better than one person's judgment. All right, Deepa, go ahead. Let's put this right behind. That's okay. I can rotate my scope so you can get this riding right there. Do you like that? All right, go ahead and take it. Deploy. Excellent. All right. Now we are 100% confident.
All right.
Excellent. Of course,
Yeah.
when the edema goes down from the injection, swallowing gets better in the morning.